Great. Okay. All right, so we'll go ahead and get going. I wasn't sure what to title this one, so I just called it a challenging STEMI that Joaquin and I got to take care of together.
So, Katie, we will ask Dom Ross what title from what movie he would apply to this presentation at the end.
Excellent. Okay. All right, so here's our case presentation. So we're up in the cath lab. This is during the day. We had a 68-year-old man without any significant medical history who'd reportedly been complaining of about a one-day history of chest pain, who presented with an out-of-hospital cardiac arrest. He was observed by bystanders who immediately got on him for CPR. Approximately about 20 minutes of CPR was done outside the hospital, followed by about 30 minutes of CPR in the emergency department with ROSC. It seems that it was initially VF, had gotten multiple shocks, and had PEA arrest after that. They had intubated him in the emergency department due to ongoing, after they'd gotten ROSC, as well as he was having difficulty. They were having difficulty oxygenating him, so he was on quite high ventilation settings down there. And when they had called us, they were concerned not only about his EKG, but the ongoing pressor requirements. When we went down there to go look at him, he was very hypotensive on two pressors already, 90s over 70s. Heart rate was still in the 80s. He was on pressure AC with a FiO2 of 100%. He looked very ill. They had him in a C-collar. His pupils were fixed and dilated. His JDP was elevated, and he was cool. They had also tried to put in a emergent central line via his right femoral, and there was a very large hematoma surrounding that, which will become important kind of later on. So this was the EKG that we got initially. Ischemic in appearance, but didn't show necessarily any sort of, like a coronary distribution on here.
So I'd like to, if you go back to that ECG, I mean, to me, this is, well, let me start by asking what people think of this ECG and the story that Dr. Lutz just presented.
Yeah, I will read this EKG as a dying heart.
You and I are on the same exact wavelength as this is the pre-death EKG. It's not far from this moment, and I think Katie and I always are talking about pace of decision making and pace of therapy, and this EKG, it's either now or never, and you just have to make the clinical judgment call early, but it is the pre-death EKG.
And for any interventionist that would take this case, I think it should be a Braveheart, William Wallace Braveheart.
I like that. That's really good. Okay, so this is the laboratory data that we had available to us at the time. pH was quite low, 6.89. Bicarb's 18, CO2 is 90 with a lactate of 11. Hemoglobin is reasonable. Creatinine was elevated at 1.6. And at that point in time, this was drawn around the time that he had gotten into the emergency department. His troponin was 149. We also have a bedside ultrasound available to us. So, the base is pretty robust, but it's clear that the apex of the left ventricle is pretty akinetic here, and is probably a little hyperdynamic at the base, which we can see kind of over here. But there was not on the ultrasound before he came up. It was not done with contrast, but it did not appear that there was any sort of LV thrombus involved in the ventricle, nor aortic insufficiency. So I'd like to pose it to the group here. You know, you have this very sick man in his 60s without prior medical history, who had a witness at a hospital cardiac arrest, who has high ventilation requirements, high pressure requirements, who has ROSC currently with an ischemic appearing EKG, with echo showing wall motion abnormalities, presumed an anterior distribution. You know, what would you consider next, and things to consider if you were to take them to the cath lab? What things would you consider?
That is a very good question. Our hospital cardiac arrest with the dying heart EKG and very severe high lactate. I think that this is a case for ECPR ECMO.
Any others? Katie, you want to share kind of what we talked about, and then how we presented options? We were very fortunate that the wife and 2 sons were present in the emergency room when Katie and I were assessing this patient.
Yeah, you know, so this is it's a very difficult decision, I think, all around. You know, on the one hand, he has a pH that's not really compatible with life, along with laboratory markers indicating that he's very sick, with concerningly inability to keep up with his ventilation. And so in the discussion with the family, we talked about you know, withdrawing care, and not only that, but escalation of care and how to best support him, which we thought would only be achievable with VA ECMO, mainly not only for the presumed anterior STEMI, but also for his high oxygen requirements and his PEA arrest that had happened as well. So those were kind of the two ways that that we described.
Yeah, I think that's I think that we have global ischemia with likely a superimposed precipitant of an anterior STEMI was our operating, complicated by VF arrest, hypoperfusion, profound hypoxemia, and profound acidemia in a person who, up until that moment, was a walking, talking, functioning individual without comorbidities who rapidly acquired them. And so in chatting with the wife and the 2 sons, you know, understanding what he would want and what they want in a very rapid assessment was important. Second, presenting to them that the patient was very rapidly progressing to death, and that it would be reasonable to do everything we could to support him in an effort to give him an opportunity to live, even if that opportunity was probably less than, you know, 30%, and that the complication rates would be high. And so we very rapidly had the heart team approach, and I don't know if you're going to have that on the next slide. Should I stop there, Katie, and have you continue, or?
No, please go ahead.
Please go ahead. And so we had a failure of perfusion to the body. We had a failure of perfusion to the myocardium, and we had a failure of ability to oxygenate the patient. And so we mobilized the ECMO team to the cath lab, brought the patient to the cath lab, intubated, obviously, on multiple vasoactive agents. And the first thing we did was place a patient via the left groin on VA ECMO. And, then figured out the steps regarding coronary anatomy and discussions about unloading the heart and what we would do so, given that this was VA ECMO in the setting of an acute ischemic event to the heart.
Yeah, absolutely. And I think even though we're making these decisions very rapidly, if we take a step back and maybe just briefly talk on the current guidelines that are in place for patients with ACS and recommendations for mechanical circulatory support from the updated, for us, the 2025 ACC AHA guidelines. And I just wanted to briefly touch on two of the studies that this was based off of. So our patient kind of fits in the SCI stage E in extremis with cardiogenic shock as the presumed etiology of AMI, cardiogenic shock with a large anterior STEMI. So it's reasonable to place microaxial flow pumps such as an Impella to reduce death. And then it's reasonable for short-term MCS as a bridge to surgery for patients with mechanical complications, which isn't his case. But there is a class 3 of no benefit based on some small studies of patients with AMI cardiogenic shock routine, and the key here is routine use of balloon pump or VA ECMO due to lack of survival benefit. And some of the primary data that comes from this is from the ECLS shock trial, which was published in 2023, enrolling about 400 some patients with the inclusion criteria of AMI with cardiogenic shock, meaning, and they define that as having a blood pressure of less than 90 as well as signs of malperfusion. And our patient would have been excluded based on this exclusion criteria of CPR greater than 45 minutes. But their primary outcome was death from any cause at 30 days. And really, it was the same for ECMO versus a more conservative therapy. Now, notably, the patients who got ECMO had increased bleeding and peripheral vascular complications, but really only 5% of the patients in this trial had received any sort of LV unloading, which we'll get into later on in this talk. And only about 15% of the control group got other forms of mechanical circulatory support. So a very sick population all around that they had here. The second trial, which is the ECMO cardiogenic shock trial.
In that first trial, my recollection is that a substantial majority of the TEAL patients had out-of-hospital cardiac arrest.
Yes, they did.
They were not simply AMI shock. My recollection is, I don't know whether it was 60 or 65% had out-of-hospital cardiac arrest with ROSC.
Yes, and it had to be with ROSC, and it had to be within that 45 minutes or less. But yes, you're right. It was somewhere above 50%, but I can't remember the exact number. In this second trial, this was a little bit less of a specific trial to AMI cardiogenic shock. This included 117 patients for immediate VA ECMO versus conservative, with the option to swap over or cross over into the VA ECMO arm. Inclusion criteria was severe cardiogenic shock. So this did not only include the AMI cardiogenic shock. This was also the fulminant myocarditis and these other etiologies here. Exclusion criteria is if they had PE or cardiac tamponade, or if they were comatose cardiac arrest survivors, which I believe our patient would have been excluded based on that as well. Their primary outcome was a composite of death, resuscitated cardiac arrest, or implementation of another MCS device at 30 days. And really they saw no difference in the conservative versus the immediate VA ECMO arm. In this group, about 17% of the ECMO group had another MCS device placed, which includes balloon pump and Impella. And about 42% of the conservative group had another MCS device placed, and 39% of this group ended up undergoing VA ECMO placement later on. So those are the two big main studies. As far as cannulation for VA ECMO here, I didn't have any photos saved of it from our procedure here, but we cannulated for peripheral VA ECMO, which is important here because it's it's different than central VA ECMO, where the cannula sits up here in the aorta and the blood flow is going with the aorta, whereas in peripheral you're putting the cannula in the common femoral, and so the blood flow is going against the normal blood flow here and causing more increased afterload to the heart, which needs to be dealt with. The other piece that for some reason didn't get saved in our images was that our patient had very small, very small femoral arteries, and so we placed a distal perfusion catheter, which is just a catheter that goes, down the femoral artery down the leg, so that they don't lose perfusion to the leg here. Okay, so once we had cannulated for ECMO in the cath lab, then we did an LVEDP and a coronary angiogram. The initial LVEDP was around 20 when he came in, and this is our first injection here. I think there's a couple of things that are important on this one. The first is that there's very slow flow in the aorta, which reflects a high afterload here from VA ECMO, and the aortic valve is really not opening very much here. Let's see, there's a little bit of overlap here, so we can't see the LAD, which we see here is, as we suspected, a completely occluded LAD right here. All right, and again, you can kind of see the course that the LAD is taking here. We were able to pretty easily wire this with a run-through coronary guide wire. We did an inflation with a 2.5 semi-compliant at 14 atmospheres, and then put in a 2.75 by 34 millimeter stent. And then we post-dilated here with a 3.0 balloon proximally. And this was the final result that we had here. So at this point, we took a shot of the right coronary. It looked fine. His EDP at the end of the procedure again is remains to be 20. And he also, as I pointed out before, he had minimal pulsatility on the aortic waveform. Would anyone consider at this point, I guess options at this point for him? We know he's got a high EDP. We know he's not very pulsatile with high afterload on VA ECMO. Things that we considered at this point were placement of an Impella, but I'd be interested to hear what others might do.
Did you camera or take photo on the arterial waveform from the console panel in cath lab?
Yeah, I wanted to take a picture of that and show it to you. There was only one aortic waveform that ended up being saved in our system, and it was very minimal pulsatility. I didn't include it in here because it really just looked like not much to see at all. But yeah, it would have been better if I had a picture of that on the console.
It was
really like a flat line, right? Flat line.
Exactly.
Yeah.
flat line. Basically, it looked like a mean arterial pressure in the mid 60s, and that was it. Minimal. I mean, it literally just looked like a straight line, but very slight undulations. So
Did you mention that he is a fireman?
Could you repeat that?
Did you mention that this patient is a fireman?
He's a
or just only ordinary patient?
just like an ordinary patient.
He's a large. Yeah,
I
normal,
think his BMI was probably 35 or something. Yeah.
Yeah, tall, healthy appearing, on arrival, outside of the typical hardware you'd expect in somebody who had undergone a prolonged code. And so, we did not think that he would survive without first putting him on ECMO. Second, opening his infarct-related artery. And unfortunately, despite both of those, he was unable to eject any blood out of his LV. And so we said, leaving as is not an option. He's not going to get better. Putting a balloon pump to unload him, probably insufficient, although we don't know that for a fact. Direct venting by our CT surgeons, not an option. So that really left us with implanting an Impella at this moment. And those were the discussions. We had our cardiac surgeon with us. We were all scrubbed together. And we had our critical care team and Katie and myself. And so I think Katie and I felt that unloading the heart was essential in an effort to begin to perfuse that anterior wall.
Yeah. Exactly. And so I think one of the things that we were combating here was, while VA ECMO can be incredibly helpful, it can also cause non-physiologic effects on pressure within the system. And so it can be helpful here for unloading RA pressure, as the cannula is sitting right around in here. But that does mean that there is going to be at the cost of elevated afterload from the cannula in the aorta here. And so over time, the left atrial pressure can increase. There's resultant, as what we were seeing, minimal pulsatility on the aortic waveform, as well as elevated LVEDP, which then can result in an elevated PA pressure and an elevated from the elevated wedge pressure. And so, multiple deleterious effects can come from VA ECMO. And so, I was very scared to present this to everyone here, but I'm going to try to walk us all through these very important pressure volume loops, because I think it really helps to drive home the point of why putting an Impella in here we thought was going to be the most beneficial for him. So panel A is a normal pressure volume loop of the left ventricle. So we're only looking at what's going on in the LV. It's measuring pressure up here on the y-axis and LV volume here on the x-axis. We've all seen this here. So if we walk through it, the mitral valve closes at this point. And the heart undergoes isovolumetric contraction until it gets up enough pressure to open the aortic valve here at this point. There's the ejection phase here. The aortic valve then closes. We undergo isovolumetric relaxation. Pressure goes down in the LV, and then the mitral valve opens and then allows for filling of the LV, and it goes this way. The green line is the intersection over here and measures the end systolic pressure volume relationship of the heart, which is also contractility. This EA line is the arterial elastance, which also reflects the afterload of the heart. This line here from the LV-EDP to the LV end systolic volume, what's within it is the stroke volume. So here somewhere, over 50 mLs. And the area of this entire pressure volume loop is the stroke work. And so if you look at panel B, we can see that the whole goal is to decrease the pressure volume area, which is included in the stroke work, the volume here, but also the potential energy that's over here in this kind of teal color here. So the whole goal of unloading is to decrease this entire area, the pressure volume area. So this area plus this area. And so that can be achieved with Impella more so than ECMO, which we'll get into F. But first, if we go over here to to panel C, we can see the effects of increased afterload of the heart. So that decreases the amount of stroke volume, and the pressure becomes very, very high. In panel D, we can see what happens with increased contractility as well as increased preload on the effects of increasing stroke volume. So if you have increased contractility, of course, you're going to have increased stroke volume. If you have increased preload up to a point until the LV dilates too much, you can have increased stroke volume. So those are kind of two of the main ways that can happen. Panel E shows us what happens in patients with cardiogenic shock and what happens to the effects of the heart after it's been on VA ECMO. So baseline is this kind of purple area. In cardiogenic shock, when the contractility, the green line, decreases, we move into this blue area. So not only is contractility down, but end diastolic pressure is elevated. And so the ability to, the stroke volume is decreased at this point in time. If we put a patient on VA ECMO, we raise the afterload and even more decrease the stroke volume that the heart can inject here. And so we see the effects of stasis, we see the effects of the afterload in the heart, which we were seeing for our patients with minimal pulsatility. This last one here shows the effects of both Impella as well as balloon pump on what happens in the heart. And so balloon pump plus VA ECMO is this kind of purple dotted line. So it does decrease the afterload, but it does not change very much the end diastolic pressure. Whereas if we put someone who's on VA ECMO on an Impella, we're both decreasing the afterload, and we are, kind of bringing them down to unload the heart, which is the whole goal of decreasing the pressure volume area here. Any questions or comments on on any of that?
That's a beautiful explanation of this very, very complex pressure volume relationship. Yeah, but I have no idea, but that's excellent for the explanation. I have to go back and study the physiology again before I can comment.
Yeah, so
Absolutely.
Katie, I think you did a really nice job of understanding that although the VA ECMO improves in-organ perfusion, it adversely impacts the afterload of the heart and consequently raises the end diastolic pressure. And by adding the Impella circuit to unloading the heart, you decrease wall stress and lower the left ventricular diastolic pressure. And the way I think about this is it really depends what patient I am treating. I have a very low threshold if I have a STEMI complicated by shock and inability to ventilate somebody that I put on ECMO. I will always afterload that patient. Very different than a out of hospital cardiac arrest who does not have underlying coronary disease, or a patient with shock that we are trying to recover that does not have a STEMI. In those cases, I'll use a different echo parameters and the pulsatility and determine selectively who I will unload with either a balloon pump or a Impella. But my own practice is in the rare cases that we have AMI complicated by shock requiring ECMO, I will unload.
Absolutely. And I think, your comment really had a good segue into this, who to unload and some of the features that we do look for. So clinically, refractory ventricular arrhythmia or development of pulmonary edema. But echocardiographic features, as Joaquin was saying, increasing LV dimensions, if there's stasis of blood in the LV cavity, if they've developed some sort of an LV thrombus, although that would not be great for placing an Impella into the LV. If the aortic valve is not opening, which is what we were seeing in our patient, and if our LVOT VTI is very, very low, less than 10, these are all the echocardiographic things that we look for if should we unload the patient. Hemodynamically, we were seeing some of these things: pulmonary elevated wedge pressure and a lack of arterial line pulsatility. This group that I took this from had a very nice flow chart, which can help when we need to make these tough decisions. So if the patient is supported on VA ECMO, then the goal is to titrate the ECMO flow rate to the minimum that's required to achieve, perfusion parameters. And do they have any sort of clinical complications or echocardiographic complications, which we just discussed? If yes, then we could consider LV unloading. Otherwise, they have any sort of other adverse clinical features, LVOT VTI of less than 10, increasing LV dimensions, these types of things. Do we have room before we just LV unload them to add some inotropes or try to optimize their fluid status before placing another device? And again, as we go down the flow chart, there's the strength of evidence to guide these recommendations does decrease. Is their wedge high? What's the etiology of cardiogenic shock? And if we think that they're going to recover, then early LV unloading may be preferred. And then these are the other things that they suggest monitoring for. Okay, so Back to our patient, we ended up, placing an Impella for the multiple reasons that we discussed here. So we went on the other side, so contralateral to where we had already placed the VA, the aortic cannula here. It was on the same side as the inflow cannula, unfortunately, because due to the patient anatomy, the femoral vein was located essentially right underneath the femoral artery, so it was actually very hard to access. And they luckily, even though he had a large hematoma on this side, Joaquin was luckily able to advance a wire up through here and salvage that femoral line. So these two cannula, so the Impella and the inflow cannula were on the same side. Here's our Impella here. It's sitting nicely across the aortic valve. And you'll notice that the inflow cannula looks like it might be a little bit high up here. So normally we want to see it at the RA SVC junction, and it's looking like it's a little bit on the high side, which is important here because the patient remained fairly hypotensive and nearly had a PEA rest when they transferred him off the bed. And so we put him back up, put him back onto the table and reposition the inflow cannula. I'm sorry it's not projecting as well here, but the cannula is now down here, and he was much better supported after moving the cannula down. And so for this patient, did have an unfortunate hospital course. He was started on targeted temperature management and unfortunately had neurologic complications and anoxic brain injury and brain herniation that unfortunately was not salvageable. And so he ended up passing the next day. So some key learning points that I had along with Joaquin was we have to select patients for VA ECMO very carefully, and Joaquin has discussed a lot of these important points already. And for us, there's several clinical factors and echocardiographic factors, hemodynamic factors that once we have VA ECMO in place, that warrants considering unloading with Impella assistance. So those are the learnings that we had. Happy to answer any questions or facilitate some discussion here.
That's a beautiful case, and we learned a lot from your decision making and the limitation, the severity of the patient. When you look back at Dr. Thiel, the ELCS criteria, they say that the out of hospital cardiac arrest of less than 45 minutes. In our AICT is Asian Interventional Cardiovascular Therapeutic Society. I used to be a member of AICT before I retired. We have agreement that in ASEAN, where the resources is limited, we will consider the ROS within less than 30 minutes. If it is longer than 30 minutes, just let him pass away. As we saw from EKG that the EKG was a dying heart. And then you demonstrate the echocardiography, there was a hypercontractility on the basal segment of the LV, but not at the apex. And basal segment did not help anything. So we still consider of 30 minutes of the RSC. If it is longer than our 30 minutes, we look at the patients and we try not to push too hard. Perhaps sometimes we have to let them pass away in peace. That's my comment. But in your case, I know that in US you have to do everything to save the patient as much as possible. As I mentioned earlier, anyone who takes this case is a brave heart.
Yeah, it was a hard moment in the emergency room, and I thought he was kind of on that edge of no return versus giving him the chance. And, that I think that his total CPR was probably greater than what we estimated at the bedside. It's amazing. It's still so hard for us to understand. It was witnessed, it was initiated, but some people said the total CPR, before ROSC was, 25 minutes. Others said 35 minutes. But I think the story is told by the CT scan that showed the diffuse anoxic, which increased the hemorrhagic risk and conversion once he was fully anticoagulated. Hard case, tragic outcome. And, I think we gave him a opportunity, and one could ask the question, did we exceed that time frame or not? I must admit, during that assessment in the fog of war, I couldn't state how long or how short it was. I thought there was too much uncertainty in this guy. But we thought it would be very helpful for all those reasons to share the case. And sometimes cases with tragic outcomes, there's a lot to learn from them. And, Katie and I thought this would be an important one to share.
Yeah, there are some centers that do VA ECMO cannulation in the field. And, we're not a center that does that. But is it possible that a different outcome could have been had if potentially that had been started, earlier? Who's to say? But I think that's going to be interesting kind of moving forward as more and more data come out from those groups.
Yeah, I think even in the US, to take care of 425,000 sudden deaths that occur, the economics and the implementation would be really, really hard.
Yeah, absolutely.
And anyone have a question for Dr. Lash? I have seen quite a number of the doctors attending. Any question?
Good morning. I'm Dr. Paitun from Sukhumvit Hospital. So I want to ask that in OHSU, so your system, you prime the ECMO line and prepare for the ECPR all the time, or you just so you prepare and prime the ECMO system beforehand, right? Because in our hospital we have in our hospital due to the budget we and due to the very rare case, so we could not prime the circuit of the ECMO for the ECPR. We have to initiate the ECMO case by case.
Yeah, what I would say is we are clearly not an ECPR. We don't run an ECPR program in our hospital. And so we do have multiple circuits, and, we have one in the lab, and we're able to very rapidly initiate the circuit with our, multiple teams. And so between the time that Katie and I saw the patient and we said we're a go, and we're going to start with ECPR, with ECMO, we were able to consolidate the equipment and the personnel, prime, and, from the time the patient arrived in the lab, we were on the circuit within 20 minutes or so. I'd have to look at the log. But we typically have a surgeon who can break scrub or come from clinic, and our perfusionist, and they move quickly. But it's rare for us to initiate ECMO for out-of-hospital cardiac arrest with ROSC.
Thank you for your questions and your great case. So at Sukhumvit Hospital, we also have we have no Impella. So we have one of our case that we put the peripheral VA ECMO in the myocarditis 26 French male patients. So in that case, we have to do the LV unloading. We have no Impella. So in our institute, we put the intra-aortic balloon pump with the atrial septostomy.
Yes.
And in that case, or it could help the patients. But if we have the Impella, it will be great. So we have to learn a lot from you and also the BDMS. Yeah, thank you.
Yeah, I think those are great points, and you know, it's we don't have great pressure volume loops of IABP plus septostomy, but I think that, you know, there are many things about the IABP plus septostomy that are appealing, and primarily it is the much lower vascular complication rates of an IABP septostomy approach to unload the heart in the LA. And I frankly, there's a lot to that appeals to me over an Impella when you think about all of the real estate that you occupy in the groin and the significant risk, despite antegrade sheaths, of bleeding and ischemia that now occupy both groins.
I think the beauty of our annual monthly conference, especially from OSU, teach us a lot. I myself involved in the Ministry of Public Health, Center of Excellence. And they have a new regulation from Ministry of Public Health to open cath lab in every town, every city in Thailand. That is around 67 cities. And they have a new regulation force us to purchase ECMO for STEMI case or for non-STEMI case. Then I argue with them that ECMO is not a final solution. Impella should be a better one. But I mean, because this educational session is not provided to Ministry of Public Health, and there are a lot of old guys, the people who are in control, they still convinced or regulate centers to have to purchase ECMO in every PCI center in Thailand. That I don't know why, but this is the issue that I have to fight with them, because BDMS is part of the national services for STEMI. But I don't think that ECMO will help. This is the issue. Perhaps I may ask Dr. Sigarua, as a vice president of SKY, to write a letter to our Minister of Public Health to guide them.
I'm happy to engage, and maybe when we're there in November, we can meet.
Yes.
Thank
Yes.
Thank you, Prof. Anyone else have question? We still have some time.
You did an awesome job presenting, and I was very impressed by your pressure volume explanations.
Yeah, we have an excellent integrative cardiology lecture series that goes throughout all 3 years of fellowship here at OHSU. And so that certainly helped facilitate that for me.
For that pressure volume relationship, as medical student, I hate this topic as the most.
You know, I agree with you. And I think for me, the most areas of growth have come when I've been uncomfortable. And so I was uncomfortable revisiting them yesterday evening.
It could have been a
You are
little more
great. You are great.
uncomfortable.
You are great on explanation, everything to us. You are great.
If you had a pressure volume loop and the Krebs cycle on 2, that would have been.
Yeah.
I still remember some Krebs cycle.
Impressive.
That one, that gives me PTSD, Wanapa, the Krebs cycle.
Anyway, thank you very much, Prof. and Dr. Luz. And thank you everyone for the comments and participation today. Thank you. Have a good day.
Have a wonderful day. Thank you.
Thank you.
Okay, thank you. Bye-bye.
Bye.
Bye-bye.
Thank you.
Great case. Thank you so much.
You bet.
Good to see everybody.
Likewise.
Yeah.
Bye-bye.
See you.